All right, welcome back. Still here with us is the coordinator of the Every Breath Counts Coalition, Leith Greenslade. Leith, thanks for staying with us. We were obviously talking about prices before the break. Now, when it comes to setting a price for something like, say, for example, you'd mentioned an oxygen concentrator in part one, how much of it is determined by market forces versus governments and their subsidies, for example?
It very much depends on the country. So in countries like India, we've seen the government is very comfortable setting price controls or ceilings on prices, but most governments are not comfortable in, interfering with the market in that way. So in most countries, it's market forces. So if concentrator prices rise, as they did, governments have to pay those prices. So the deeper you go into the pandemic and the worse the oxygen shortages got, the higher the prices were to pay for the goods. So some of the international agencies that I work with, they try and influence that by pooling what they call procurement. So they all try and join forces and say, okay, we're going to go to a company and say we're going to buy a huge number of, say, oxygen concentrators to try and bring the price down by buying in bulk. And by and large, that works. It's just that you need a lot of money to be able to influence the market, shape the market in that way.
And because of these exorbitant prices of oxygen, obviously during this period, it's led some people to sort of see it as a luxury commodity. What's your assessment? What's your take on that term for oxygen?
That's a very harmful term for oxygen. Oxygen during COVID is the basic essential medicine to treat COVID. If you get severe COVID and you're in a hospital, which is where you should be, but many patients are not, they're at home, oxygen is the first thing you'll need. It's foundational to COVID treatment. Without it, you'll die. You'll suffocate to death. And the images we've seen those images of people suffocating to death from COVID. It's happened because of lack of oxygen. Nobody should ever have to die that way, and no family member or healthcare worker should ever have to stand by and watch someone die for lack of oxygen. So it is the most essential medicine to treat COVID, and the WHO have said so.
Now, when it comes to these out-of-pocket expenses that we were talking about earlier, what role did insurance companies play in these crises, and what role should we expect from national insurance schemes when it comes to oxygen coverage, for example?
Well, if you happen to live in a country where you have health insurance, you're fine, usually. So if you live in a country like the UK or some of the European countries that have a national health insurer, when you go to hospital, that is covered. Oxygen is covered. In the US, you go to hospital, you have private health insurance, so there can still be a massive fee. Many patients in the US have left hospital with massive bills from COVID. They've had their oxygen, they've had good quality of care, but they still have to pay a huge sort of gap. But in many of the countries we work in, lower middle income countries, there is no health insurance at all. So you have to pay your hospital bill when you come out of hospital. Or sometimes they won't even admit you to hospital without proof that you can pay. And that's why we've seen so much COVID treatment, or one of the reasons we've seen so many patients with COVID in Africa, Asia, Latin America. They just don't go to hospital. It's because of the fees, and they're treated at home. And their families buy oxygen and whatever other medicines they can get their hands on privately. We saw that in India too, in Nepal and parts of Asia. So once again, if you're lucky enough to live in a country that has health insurance, you can have the cost of that oxygen come down, but there are still many countries that don't have insurance.
Now, when it comes to the developing countries, especially, did you see any sort of distinction in perhaps private care versus public care for these oxygen-deprived patients who were in need of these products, or was it essentially the same across the board?
We saw oxygen shortages across the board.
Okay.
So the private hospitals, and there in some of these countries, there's a vibrant private hospital system. It tends to serve the middle and upper classes. And typically they would have a better quality of care, often because it's paid for by middle class and upper class families, individuals who can afford to pay. But the oxygen shortages were so acute in so many countries, we saw many private hospitals run out or not be able to source. So it didn't matter whether you could afford to pay or not, there was still no oxygen available. So that's how bad it got in 2021. And we are desperate that this never happen again in 2022. So everybody is working very hard at the moment to make sure that all hospitals, whether private or public, have the oxygen they need going into 2022.
Now, we obviously talked about India a fair bit when it came to the oxygen crisis. Now, when it was deployed at a faster rate across the country, we also started to see cases of black fungus emerging among many people who had been using various contaminated oxygen cylinders or products that was clearly an oversight when it came to perhaps hospital management or the distribution of these devices. Does it seem to be a long road ahead in terms of training people to identify problems like this to ensure better management, say, in these countries?
Yes, it's a long road ahead because we were starting on oxygen. We were starting so far behind. So not only did we not have the oxygen supplies that we talked about earlier in many of these countries, but they didn't have the trained people. Oxygen is quite complicated to work with and it can be dangerous. We've seen oxygen explosions in several countries which have killed people. And we've seen, you mentioned the black fungus, we've seen all sorts of complicating issues that occur when the oxygen is not handled properly or there's contamination that gets in. So this is quite a technical area of health, and we haven't had the experts, the oxygen experts and the biomedical engineers in the hospitals and in the health ministries that can work with oxygen. A lot of that expertise is often locked up in heavy industry. So you have excellent technicians in oil and gas and steel, mining. But when it comes to the poor old hospital system, they don't have access to that kind of expertise. So another aspect of what we're trying to do is not just provide the products to hospitals, but the people, the skilled people, to make sure everything is installed and works properly. And we have a long way to go. It's quite easy, if you think about it, to move oxygen from A to B, but to take an individual and train them from scratch to work with oxygen takes them a lot longer. And we've had a pandemic. We couldn't meet face to face. We couldn't fly in experts to train local teams. We had to use virtual, Zooms to train people. So it was a perfect storm, really. And I know there's controversy at the moment. Nobody wants to say how many of those 5 million COVID deaths that we've had are the result of lack of access to oxygen. We have our own assessment of that. It's quite a considerable number of deaths occurred in several countries because of lack of access to oxygen.
Now, obviously, the coalition has been looking into respiratory issues for some time now, like pneumonia, for example. What are some similarities and differences that you've seen in oxygen management and distribution when it came to those issues versus COVID-19, say?
So lots of different patient populations need oxygen. This is not something that hospitals need just for COVID. I mean, the thing about oxygen is the tiniest newborn, a lot of newborns are born with respiratory distress and they need oxygen. A lot of children, and pneumonia is the leading killer of children under 5. A lot of people don't realise that. So, and a lot of children with pneumonia need oxygen. Sometimes women need it in childbirth. Adults with both chronic conditions, chronic respiratory conditions, need it. People need it for surgery, and many people need surgery in their life. So oxygen is something that's essential across many patient populations. So the difference, as I mentioned before with COVID, is the sheer quantities of oxygen COVID patients needed to consume. That was what was different. For some reason, this particular respiratory infection really knocks out the respiratory system, and you just need help breathing for a very long period of time too. We've heard stories of people on ventilators for weeks and weeks and sometimes months. That's different. That's what was different about COVID.
Now, the coalition is also sort of looking to get good quality oxygen to hospitals in many of these countries over, I believe, a 10-year period. Could you tell us a little bit about that plan and how you're planning on implementing it?
Well, we want every country, and we work mainly in low and middle income countries, they all need to have what we call national oxygen roadmaps or national oxygen plans. They need to sit down and assess every hospital in their borders in terms of what it has and what it doesn't have. And if there's a massive gap in access to oxygen, that gap needs to be filled. And it will take a long time. 10 years is a long time, but that's the time span we're putting on doing this properly. They need to make sure the hospitals have an oxygen source, a reliable one, and a backup one, and then all the trained staff that they need to operate, to maintain that equipment, because this equipment needs to be maintained over time. It's like anything, it can break and it needs to be serviced and repaired. So every country needs that. And they need it for their non-COVID patients, all the patients I mentioned before, but they also need it because we're pretty certain we're going to have another respiratory infection pandemic. As bad as this one has been and continues to be, the scientists tell us that we're going to have more of these for a variety of reasons: climate change, urbanization, rising air pollution. There's all sorts of factors that are combining to make respiratory pandemics more likely. So countries have to consider oxygen in terms of their pandemic preparedness and response strategies. And we're encouraging them to do that, and we have organisations available to help them do that.
Now, bearing in mind what you've said about how that could be another potential crisis, on the horizon, one report said that medical oxygen made up just 1% of global liquid oxygen production, which for the most part, as you mentioned, is dedicated towards industrial processes, and that's where the expertise is also located. Could we start to see that change now, and why was it so low to begin with?
Well, we better start to see it change. Liquid oxygen is really the primary market for liquid oxygen has been heavy industry, as I said before, steel, oil, and gas mining. And the hospital system has been a tiny part of their market. Now, our proposition to them is that's the problem. This needs to be a much larger segment of your market because there's so many underserved hospitals that need liquid oxygen. And over time, this needs to grow. If it's currently 2 or 5%, it needs to triple, maybe even quadruple in terms of the proportion of your business that medical oxygen is. Now, they're going to need to work hard to reach that market because these multinational companies are based in Europe, Japan, and the US, and they have struggled to really reach the global south. These are tough markets for a lot of them. There's a lot of capital infrastructure around liquid oxygen. You have to set up big air separation units. It's intensive. But we've told them that this is what they need to do. And if they do it properly, there's growth markets for them here. This is a business proposition. This is not charity.
Leith, thank you so much for being on the show. Really appreciate it.
Thanks for having me, Drew.
Really appreciate it. And that's it from us here on All About Money. We'll see you again next week.